your day to attend the very first FSR 2025 Town Hall meeting. And to kick off this year's event, we have Jean Acevedo, who actually needs no introduction to anybody up here on the group. She is the president and emeritus president, at least from all behalf for us too. And she has always this valuable and great insights that keeps us on our toes and keeps us wondering as to what else, how low more can CMS go. When we think it's to the bottom and Jean comes back and lifts the spirit some more with some more enlightening news. And to help us out through for today, let's have Jean take over and we start off on a good day.
Thank you, Manish. Let me see. Am I able? It looks like, yes, I am able to share my screen. So thank you all for having me again today. It is always a pleasure. This is my special little group, the FSR. Let me move that. So I'm always happy to kind of move you towards my goal for you, which is I want you to get paid every dollar you're entitled to, just not a penny more. Right? So, and I know that over the last few months, there are plenty of targeted probe and educate audits going on, especially for 99214. Most of the, well, actually all of the rheumatologists that I've had the pleasure of working with and responding have passed. So let them try somewhere else. All right, but this is another topic that is really critical to your proper reimbursement, Modifier 25. And I know sometimes when I speak to physicians and I'll say something about, well, you need to understand Modifier 25, the response I'll very often get is, Jean, I don't know about modifiers, my staff do that. So I've tried to today take a little bit of a different perspective so that hopefully for this illustrious group, I'll be, as they say, speaking your language. So my disclaimer is basically, as I'm sure you all know by now, I've tried my best to have this information be accurate today, but things in my world, coding and compliance, have a habit of changing. So God only knows what it'll look like at the end of the year. That having been said, I don't expect to see or hear of any changes to the use of this modifier. So what the heck is it? And why do you need to know about it? So modifier 25 is one of those 2-digit suffixes that the AMA created. It's in your CBT books that further explains to the payer why you should be paid for your visit, your evaluation and management service, on the same day at the same session that you performed another procedure or some other service. And I said the words the way I did because physicians of the same specialty in the same group practice are considered the same physician. So regardless of how many rheumatologists might see the patient today, not like that happens at all often, you're all considered one doctor, so this would apply to you. It also speaks to, I had on a side note, you know, I'm always going to side notes, conversation with a practice in another specialty earlier today about new patient visits. And so one thing, since not everybody is practicing in a true single specialty rheumatology practice, please make sure you remember that if you do rheumatology and you have a sports medicine physician and an internal medicine physician or whatever other specialties, different physicians in the same group of different specialties can charge as if they didn't even work together. Some of it has to do with how you're registered. So back to Modifier 25. Why is it a big deal? Well, it is the modifier that would allow you to get paid for an evaluation and management service the same day as the procedure that you may have performed and are also expecting payment. There have been studies by the Office of the Inspector General, and I think I have results coming up in a second. So I know that the federal government considers it upcoding, not a good word, upcoding if a physician or non-physician practitioner submits a claim with Modifier 25 on their visit when the patient care rendered was not medically necessary, wasn't distinctly separate from the other service provided, and was not above and beyond the care usually associated with the procedure. The most obvious instance of this not being done properly that rheumatologists can typically relate to is the patient who comes in for their Prolia injection, gets seen by the physician before the injection. Some practices still do this. And the note reflects the fact that the doctor has looked at their calcium, their vitamin D, they've confirmed that the patient is still taking their nutrients, their supplements of those vitamins, don't have any dental procedures scheduled, etc. So evaluated all of that, patient's fine to go ahead, Nancy nurse, give the patient her Prolia. That doesn't support Modifier 25. Everything I just talked about is related to whether or not the patient can get the injection. And believe it or not, for those of you who aren't clear about Modifier 25, all of that work is included in the administration code, the 96401 or 96372, depending on the correct circumstances. And why are payers still looking at this? Well, here's a snippet from the OIG's report, where they have provided those CBRs, a comparative billing report. So for Modifier 25, you, doctor, what's the percentage of E&M services that you report with Modifier 25? So this shows that 46 out of 100 claims that have an E&M service have also Modifier 25. What for this doctor is the typical percentage of that usage in their state? 23%. So the result, obviously, is that this doctor is significantly higher. And then also comparing the utilization on a national basis, 21%. So obviously still significantly higher. And significantly higher is not a result that any of you want when the government's looking at you. So if you look at this, and of course, this doesn't say that these doctors were doing anything wrong, but the doctors who were this much significantly higher than their state or national peer group are setting themselves up for an audit. Also, not the end of the world. I just finished saying that every rheumatologist that I've had the pleasure of working with the last several months who had a level 4 visit audit have passed, most of them at 100% accuracy. But it does mean that you need to understand it, right? So if you're more apt to get an audit, would you pass? That's the important thing. So part of helping you understand why the heck we even have this modifier, because I understand it's counterintuitive, right? Here's the why. Procedures or services have detailed components that are integral in the performance and reimbursement of each CPT code. So whether it's a trigger point injection, an EKG, any of an IM injection, all of those therapeutic procedure codes in the RVUs have a component of physician work. And you know that your injection procedures are all bundled into the surgery section. So when these things say surgery, it is appropriate because they're also looking at the code set, right, in the CPT code book. So the procedures that you're performing include, in their payment, evaluation and management service subsequent to the decision for the procedure on the day before and or the day of surgery, local anesthetic, which I think everybody knows by now, immediate post-op, post-procedure care, including dictating notes, talking with the family, other physicians, excuse me, writing orders, evaluating the patient after the procedure has been completed, and whatever typical post-op care. So the example I give you at the bottom is like 20611. All of that is included in your large joint aspiration code. So specifically, what does that mean? So I went up, for your edification, to the physician work time file. So one of the things that I spotted a few years ago is that when the proposed physician fee schedule rule comes out each year, there are probably 10 or 20 Excel files that are also put up on the website. And they have a lot of that detail that backs up why CMS is saying, that the work RVUs are too high or this utilization, et cetera. So for 20611, total time that has been put into the formula for payment in the RVUs that is expected that the physician spends is 27 minutes. 12 minutes for pre-evaluation and positioning, scrubbing, waiting for the MA to come in, whatever it might be. 10 minutes for is the median amount of time for actually performing the injection procedure. And 5 minutes for putting the Band-Aid on and telling me to ice it, keep my leg up today if I can, etc. So, and I found this really surprising. 27 minutes for a knee injection? Because these are code specific. Now I've given you the link here. So if anybody went, what the, and wanted to go look for other things, I know one time I looked up trigger point injections, 20552, and the pre-evaluation, positioning, yada, yada time was 5 minutes for a trigger point injection. So if you start to think about, well, wait a minute, the payment system feels like it's paying me for 27 minutes worth of my time, including 12 minutes to determine exactly the right procedure. Is it okay? Any contraindications, et cetera. I'm hoping that you can start to see how important it is to know when to use and when not to use Modifier 25. And Modifier 25 tells the payer again that, hey, I know I did a procedure and all of this was included in that procedure code. But in addition to that, I documented and performed significant and separately identifiable services. And your documentation needs to be clear and clearly reflect care above and beyond the usual care you would provide for the day's procedure. So you need to have provided services that are not a normal part of the procedure. So think about my Prolia example I gave you. There was nothing else really that was addressed. My experience reading notes is that that's kind of routine for any patient coming in for their injection procedure, right? So it has to be something above and beyond, significant and separately identifiable. If the patient is scheduled for an injection or infusion, ask yourself, what else was addressed? And remember, to bill an E&M code, you still need a chief complaint. No one's counting bullets, but the medical necessity of the problem is still required to be documented. So what's the chief complaint? What's the medical reason for the visit? And did you describe the presenting problem of that condition in your history? In fact, in the visits that don't typically qualify for Modifier 25, i.e. aren't really separately billable, did you even really did you really even document how the patient is presenting today? So CPT says that this modifier indicates that on the day a procedure was performed, the patient's condition required a significant, separately identifiable E&M service. You're starting to see the verbiage is repeated over and over again, above and beyond the other service provided or beyond the usual pre-procedure and post-procedure care associated with it. The E&M service may be prompted by the symptoms or condition for which the procedure or service was provided. So I'm your patient. I come in today and I go, I'm not quite sure what's going on, but remember I had mentioned to you that my right knee was bothering me. Well, now it's starting to wake me up at night. I'm having difficulty walking up the one step to get into my house. And you take some more history and you examine my knee, and you suggest that I get a large joint arthrocentesis with a steroid today. Well, you had no idea that you were going to inject me, and the degree of history and exam you did would clearly be above and beyond the usual pre-procedure care associated with an arthrocentesis. So it might be prompted by the symptom, and a differing diagnosis for the E&M and the procedure is not required. Although I will tell you that where there are two different diagnoses, it paints a picture much clearer to the payer. So where there is one. So parsing out the E&M service, what chief complaint and history of the present illness is unrelated to today's procedure? Is there an exam in addition to what you would routinely do in preparation for the procedure? Is there evidence of some medical decision-making or decision for a treatment option not previously decided? And with all of this is probably one of the reasons why, at least here in Florida, First Coast Service Options, our traditional Medicare contractor, does not even require Modifier 25 on a new patient office visit when there's another procedure. Because the logic, and yeah, even the Medicare program sometimes can be logical, to them is, look, you never saw the patient before. There's no way that the patient walked in the door and you looked up and you went, yep, let's do an injection, right? So there is definitely going to be something separate and significantly identifiable. You have to do all of this work up to be able to come up with whatever the treatment options are, right? So it's all about your documentation. Shocker, right? Your chart should document an important, notable, distinct correlation with signs and symptoms to the E&M service to be able to make a diagnostic classification and demonstrate a distinct problem. So also for your ICD-10 coding. So let's look at a couple of examples. These come from the CPT Assistant, the AMA's publication. So example number one, let's see whether or not Modifier 25 is supported per the coding rules. A patient complained of left knee pain. At a previous visit, you evaluated the knee, you ordered a prescription of an NSAID, and scheduled a follow-up visit in 2 weeks after performing the arthrocentesis if the symptoms had not improved. The patient returned, and at that 2-week visit, you performed an arthrocentesis, an injection of the left knee joint, and scheduled a follow-up visit for a month later. So at the 2-week visit, do you think that Modifier 25 would have been appropriate on an E&M service? Nope. It would not be appropriate to report the office visit at the 2-week follow-up because the focus of the visit was related to the performance of the joint injection. So only 20610 with whatever J code would be appropriate. So when you know that the patient is having a procedure, it's a planned procedure. Unless there's another problem, it is uncommon for there to be a billable E&M service to support the Modifier 25. When determining whether to append Modifier 25, you should address the following questions. Was the physician's evaluation and management of the problem significant and beyond the normal preoperative and postoperative work? And you all know that 2-week visit in the prior example, there wouldn't be. You would obviously ask me in the 2 weeks follow-up so Jean, so you're back, so your symptoms haven't improved? Tell me, right? So you'd get a history to make sure that performing the injection procedure was still clinically appropriate. You're probably going to examine my left knee because you want to make sure there's no effusion, something that would be contraindicate the injection, but you wouldn't do the injection procedure without doing either of those, right? So those would be services that are inherent to the procedure and those 27 minutes, not separate and significantly identifiable, right? Ask yourself, was the procedure scheduled before the patient encounter? If yes, then it wouldn't be medically necessary to report an E&M service unless the patient had other concerns or problems that were addressed during the same encounter. So, and These may not be current. If you look, this is from March 2012, so 13 years ago, but nothing's changed about Modifier 25, which I think is why this is one of a couple of topics that the federal government doesn't understand why doctors and their staff don't get it, and their patience starts to wane. So this flow chart comes from, I think it comes from Novitas, which, as you probably know, is our MAC, First Coast Service Option, sister organization. So it would take you through this thought process. Was a procedure performed on the same day as an E&M? No? Well, then don't stick a modifier 25 on your office visit code, doc. If the answer is yes, was the visit significant and separately identifiable? Yes. What I documented, what I did, the history I took, and/or the exam, and my medical decision making had nothing to do really with this procedure. Then bill the E&M code with modifier 25. And one of the things that I often forget to say is that your injection procedures fall in the category of a minor procedure with 0 global days, right? So there's no other service bundled into your injection procedure the day before or any days after the procedure. But what I often forget to say is that in the same guidelines or requirements for global surgery billing, it's really clear that at one E&M service on the day of the procedure is included in the procedure code. One second. So to bill an E&M and be paid, it becomes even more clear that, oh, okay, I get it. I need something that's separate and significantly identifiable, really unrelated pretty much to this procedure I'm doing today. Unless, of course, it's a new patient visit, right? Where everything is going to support hopefully, another visit. So modifier 25 applies only to your visit codes, and only for visit codes provided on the same day as either a diagnostic or some therapeutic procedural service. It's not necessary that the procedure and the visit be provided by the same physician or practitioner for the modifier 25 to apply. Remember, if there are multiple of you in the same group, in the same specialty, you're all considered one doctor, one physician. The diagnosis associated with the evaluation and management service doesn't need to be different than that for which the diagnostic procedure or therapeutic procedure was provided. Although, like I said before, it sure as heck is helpful. And there are some commercial payers that don't follow this concept. And that's probably one of the biggest rubs in this, is that we all vetch about the Medicare program, but for the most part, we can find the rules and the guidelines for the Medicare program without too much difficulty. Of course, we need to know where to look, right? And they typically follow, again, there are exceptions, of course, they typically follow the rules that we can find in our CPT codebook. And I've never found anybody who would argue that before we bill, we got to make sure that at a bare minimum, we're meeting the requirements of a codes description, right? I mean, otherwise, how the heck do we think we could bill for something, right? And unfortunately, some of the non-Medicare payers, or even some of the, what do they call them? Medicare Disadvantage plans, create their own rules, change them without telling you, et cetera. And of course, I know you've never heard about that, right? So let's do a little bit of a test before I sign off and see if there are a couple of questions. And this is where I wish I had a poll that I could do. A 72-year-old established patient, so you've seen this patient before, presents to your office after falling and complaining of pain in his left knee. You perform a full musculoskeletal neurological exam and recommend drawing fluid from the man's left knee and injecting dexamethasone. So this doctor wants to bill 99213 with a 25 modifier a 20610 with an LT modifier and J11000. Did you do it right? Is this true or false? True. The patient's knee from his fall is new. The provider performed and documented significant, separately identifiable E&M service, which leads to the decision to perform the aspiration. You can bill both the injection and the visit. Yes. So new problem. You had no idea what you're going to do today. Assuming your documentation is pretty good, and most rheumatologists' documentation is, you should be able to bill both. 75-year-old established patient presents to the office for her second dose of Cimzia, ordered by her provider for her severe RA. The nurse checks her vitals and documents them along with the information of the medication and its administration. They want to report 99211 with a 25 modifier, 96372, and J0717. True or false? Well, you should all be raising your hands or shaking your heads. No, false. Forget the fact that there's no separate E&M service here, nothing distinct from giving the injection. For those of us who've been around for a year or two, we remember in, what was it, 2005? When the payment system of the drugs changed and we were all worried about being underwater with drug payment. And the one thing that CMS knew they could do to kind of offset that pain as we went to ASP +6 was to include a nurse visit in the payment, the reimbursement, the RVUs for all these administration codes, including 96372. So the reimbursement for those admin codes pretty much doubled. So you already paid for that. So no separate visit for today. So did you perform and document the key elements of a problem-oriented E&M service? So before you just throw on a 99213 and 99214 with a 25 modifier the same day as the patient came in for a procedure, not that you had to determine if they needed any procedure at all, never mind which one, but they were scheduled for one, carve out of your note, I'm very visual, so I'm always doing this with scissors, carve out of your note the section of your documentation that has to do with the injection procedure. Look at what you have left. Do you have at least 2 of the 3 key elements of medical decision-making to choose a code? Could the complaint stand alone as a billable service? Think about my cutting things out. Is there a different diagnosis for the visit than for the procedure? Obviously, again, you don't have to have a different diagnosis, but where there is, it obviously helps more clearly to support that there were 2 distinct services. If the diagnosis is the same, which happens a lot, did you perform extra physician work that went above and beyond the typical pre and post procedure work associated with the procedure? I always get the question about, do I need 2 separate notes? Nothing says that, but best practice, yeah. Procedure note, office visit note, and in EMRs, most of what I see supports that that's what you all are doing anyway. So hopefully that added some clarity to a very hot topic. Oh, there are more than 6 or 7 people I see. So I'm assuming I have a question or two, Dr. Rellin.
I'm looking at the chat right now, but there's not popped in as yet. I do have a question for you, Gene, and thank you very much for first bringing up this important topic. When you were showing us the example regarding the knee joint injection, you used J1100 for use of dexamethasone, which is for dexamethasone. Why would you use that in place of J1010?
So the example that I had there was from the CPT assistant. So even if codes are old, I'm not going to change the content when I'm quoting someone else.
So this is a question that's, in my
Sure.
practice, I use methylprednisolone, and the J code for methylprednisolone that is still active is J1010. Is that what I'm expected to use? In the past, I was still using J1100. So that's something that is something new that popped in. And I'm glad you showed that example. Is that something that I have to be careful about? Because one is for dexamethasone and one is for methylprednisolone.
So I know that what was it, 2 years ago now, right? The J codes changed for these substances that are injected, right?
That is correct.
And the code to use should be the one that accurately reflects what you provided.
Okay.
Yeah.
So with that, we'll open up for any questions. If anybody has, either you can put it on the chat or you can unmute yourself and please, to your heart desire, ask Jean anything.
Uh-oh, that's a wide open offer, anything. This really is, docs, this really is important because payers do look at this. Right? And and with the use of the G2211 that hopefully most of you are billing when you're not doing a procedure on the same day, the evaluation management complexity add-on code, I know I've seen a fair number of office visits with a 25 modifier where folks are also reporting the G2211 and of course getting denied. Although I did have one practice tell me that, hey, we got paid, what do we do? And my answer was, as always, straightforward. You need to send back the money for the G2211. So no questions on modifier 25. I am shocked.
Oh, indeed. Any last parting thoughts from your end?
No, I don't. Well, wait, now, Ken, thank you for a question. So let me answer Dr. Stark's question first. If you see an RA patient on treatment and has recurrent OA of the knee and needs injection, can you keep using 52 and inject knee with visits? 52 reduced procedure? Ken, put yourself off of mic. What are you billing a reduced procedure? Explain yourself. Dr. Stark, take yourself off of mute, please, young man. I don't know why 52. Oh, it's probably just juxtaposed, 25. Okay. See an RA patient on treatment, recurrent OA knee pain, needs injection. So this is where, Dr. Stark, it would depend on the particular circumstances. If the patient comes in and once again has symptoms, and it's not as if the last time you injected his knee, you said to him, hey, when you come back, if you have recurrent pain, you know, I can inject your inject your knee again, even if it's, as long as it's no more frequently than what, every 2 or 3 months. And the patient has the symptoms again, and because you know the patient, you know this is a recurrent theme, you know the injection will help, that you inject it, can you do it and still bill the office visit? Yeah, because you're also seeing the patient for their RA, aren't you, on the same day?
Yeah.
Or are you only addressing the knee OA?
No, I got it working now. So let's say I have a patient that has recurrent that's seen for RA on therapies, and they come back different visits. And on the different visits, sometimes the OA in the knee is a problem. So I'm injecting it, and I'd write independent of this visit, or not part of this visit, the patient is complaining of knee pain from his osteoarthritis. I inject it and use a 52 code. Does that raise any red flags?
So it shouldn't. If it was my patient and I was doing your billing, I would have the RA probably as the first listed diagnosis code for your 99214, in this case, probably. And then, of course, for the injection procedure, have the first listed, well, actually, the only ICD-10 code as the code for the OA, right? The fact that it's actually a nuanced question, if I'm hearing you correctly, the fact that the patient might need fairly frequent injections, right?
Mm-hmm.
Does not in and of itself negate your ability to bill an office visit with modifier 25, right? Because now, as you all know, I think I am a rheumatology patient, right? And on occasion, you'd be shocked to hear, on occasion, I need a joint injection. Right? So, but when I see my rheumatologist, and I do need and receive an arthrocentesis, it's not as if that day he knew I was going to get a shot. He had to make the determination, right?
Right.
What were my symptoms? How long had they started? Look at my chart to see, well, when did I inject her last, right? To make sure it wasn't too soon. Do the physical exam. And most importantly, he actually has to, at that moment, make the medical decision making to re-inject me. So as I was talking to you, and I'm always looking for ways to say it that I'm crossing my fingers that a physician can relate to this crazy billing logic. In the example you gave me, you have to make a medical decision before you inject. That patient wasn't scheduled for an injection. And by the way, you also saw him for his RA that day, right? So the fact that you had to make, and I'm assuming your documentation is pristine, Dr. Starr, you had to do it, you had to evaluate the patient's circumstance, check back when did I give the last injection, do a physical exam, and then make the medical decision making to inject again. To me, on the surface, and of course, I'm going to say without seeing the documentation, that modifier 25 should be supported. Good question, because it had so many nuances. Thank you. You challenged my brain a little bit, and I always like that. Did I answer well?
Yes.
All right. So I see I have something else. If a patient comes in for a scheduled intramuscular injection, such as ketorolac, and the injection is administered by a medical assistant, would it be appropriate to bill CPT code 99211 in addition to the injection code, or would that not be applicable? So the 99211 in the RVU system is included in your injection code. Every IM sub-Q IV injection infusion includes a 99211 in the payment. So you would never bill a 99211 in addition to an IM sub-Q injection code. I did a NORM webinar couple of weeks ago, 2 or 3 weeks ago, on modifiers in rheumatology. And there was a situation that I was handed that kind of is applicable here. And it was someone had asked about the patient who comes in for their infusion, has a reaction, and then comes in tomorrow to get the rest of their drug. And I looked at that example and I went, oh my God, there's a lot going on here. And again, very nuanced. I need more facts. So here's how I answered it. And you'll understand, I think, why I'm talking about the 99211. So one, if indeed the patient, so if the patient's infusion was not complete until tomorrow, my recommendation would be to bill the entire session tomorrow. So when it's complete, right? So the patient completed their hour, whatever it is, of whatever the drug was, maybe Remicade, J1745, right? I would bill that tomorrow when it was complete, because you don't want to be billing it on 2 days, right? I mean, you're going to set yourself up for day 2 for failure, right? And if that's the case, and the nurse following the doctor's order, because I'm hoping none of your nurses would go ahead and treat a patient's reaction on their own without asking you about it. So if the nurse documented what the doctor said and then maybe administered whatever the other medication was to counteract the reaction, that day when you were no longer billing for the infusion would be a 99211, a nurse visit. Because you wouldn't, even if the doctor didn't see the patient, but you wouldn't want to lose that. So I hope I didn't make that too confusing, but that, Jennifer, that question made me think about it.
Oh, man. With that, Jean, thank you so very much.
You're quite welcome. Thank you all for having me again. Have a wonderful evening.
Thank you.
Take care.
Take
Thank you.
care. Bye.
With that, we do have a second part to this meeting today. We do have Mitchell Zoerhoff, who's presenting on behalf of Sanofi for update in the Medicare prescription drug plan. It's looking into opting in and the impact of the smoothing process, how we have weathered the first 3 months in this fiscal year and how this has rolled out. So Mitchell will give you the floor for the next 10-15 minutes.
Absolutely. Thank you so much, Dr. Milan. Good evening, everyone. Thank you so much for having me. It's a pleasure to be here to talk about such an important topic. Some have referred to the Medicare prescription payment plan as the most important thing to happen to Medicare since the passing of Part D in the early 2000s. So it's a very important thing for patients in particular, and we're seeing a lot of data that points to just how impactful this is to patient affordability. And I'm happy to speak through that. I do have a number of slides that I'm going to pull up here just to structure the discussion. But my preference is really to have this be more of a dialogue. So feel free to interrupt me with questions you may have. I'm curious to get the participants' experience on this topic as well. I know that the Medicare prescription payment plan has been live now that we're in the second week of March for some time here, so plenty of opportunity for some patients to enroll, to kind of experience that difference in copay or co-insurance to their plan directly as opposed to the pharmacy. And so would love to hear that. So maybe to start out, if folks wouldn't mind either any brave souls being willing to come off mute, or if you want to drop in the chat just your experience or comfort to date on Medicare prescription payment plan. Is this something that you've engaged with your patients on? Do you have patients that have signed up for M3P? Do you have some frustrating experiences that either you or your office staff have gone through with your patients on M3P? Just to really level set here on kind of the tone of this group. Any brave souls willing to either speak up or maybe drop into the chat what their experience has been to date? And it's no worry if not. We're actually seeing still a very broad spectrum on education and awareness of the Medicare prescription payment plan, not only across healthcare providers and prescribers, but office staff as well as patients. And that's understandable because it can be a pretty intimidating topic for patients, as well as a relatively complex topic. So we'll try to keep it as digestible as possible here, and make sure that everybody's comfortable with what this topic is. I am going to level set here on exactly what the Medicare prescription payment is, just to make sure that folks are aware. The story of Medicare prescription payment plan actually began in 2022 with the passing of the Inflation Reduction Act. So this has actually been in the works for quite some time. Folks may remember that the IRA was a pretty sweeping bill that was intended to address a number of different topics, one of which was drug affordability for Medicare beneficiaries. There were three main buckets that were included in that legislation to help address that. One was just limiting premiums that beneficiaries had to pay year over year, out of scope for this discussion. But something that is a little bit more in scope is the capped out-of-pocket spend. So folks may remember historically for Medicare Part D coverage, out-of-pocket could be as high as $8,000. There's been a number of changes that have been made. One with eliminating the 5% co-insurance requirement in that catastrophic phase that was eliminated in 2024. But then also in 2025, eliminating the coverage gap or the donut hole as well. So this has had a very real impact on patient out-of-pocket spend. It is capped at $2,000 for all Part D spend in calendar year 2025. That'll continue in 2026 and beyond. So great news for patients. They'll never pay more than $2,000 out of pocket for that Part D spend. And that's true for all of their drug spend. That's not just specific to one prescription or one product. That's all of the products that they might have for 2025. That's all great news for beneficiaries. There's no action required on their part in order to take advantage of all of those things that I've talked about today. But they will have to take action to take advantage of the Medicare prescription payment plan. So hopefully folks are familiar with this topic, often referred to as smoothing, but this is a very powerful tool to allow patients to essentially spread out the costs of their coinsurance or their copayment for their prescription drug spend. So again, I'll just remind folks of what the Medicare prescription payment is, as well as what it is not, for those that might not be familiar. The Medicare prescription payment plan, or what I'll just refer to as M3P, that seems to roll off the tongue a little bit more easily. Although interestingly enough, CMS has publicly stated that they won't be using an acronym for this. So we'll use M3P on this call, but after this, you might have to refer to it as the full Medicare prescription payment plan. This is exactly that. It's a payment plan to make drug spend for Part D beneficiaries more affordable. So the way that it works is, rather than paying the pharmacy whatever that copay or coinsurance would have been, if a patient is opted in to M3P, they can pick up that product for free, either at the retail pharmacy, maybe they can get it shipped to them through mail order or specialty pharmacy, for no out of pocket. Instead, they will be receiving monthly bills from their health plan, spreading out whatever that cost would have been into more manageable monthly payments throughout the rest of the year. I've got a few examples just to walk through exactly what that might look like to make it a little easier for you to digest. The Medicare prescription payment plan is free to join. There's no interest, there's no late fees for beneficiaries. This is really a great tool for Part D enrollees because it takes what would have been traditionally maybe a larger lump sum payment that they would have made, and instead spreading it out over the remaining months of the year. And we're finding through research that this is actually very impactful to patients. One study looked at different scenarios of a patient paying different copay amounts, and one of the questions was, hey, if you had to pay an out-of-pocket for a higher cost biologic, let's say your out-of-pocket was $3,300 and you had to pay that all at once. Well, of course, that willingness to pay was lower. It was probably in the low 30th percentile. A similar question, but capping that out-of-pocket at $2,000 increases that willingness to fill that script slightly, a few percentage points. So it goes from low 30s to maybe mid 30s. So an improvement, as you might expect. If it's cheaper, chances are at least some people might be more willing to pay for it. But when we ask that same patient, hey, what if you got that same product for that same total cost, but instead you were able to spread it out over the remaining months of the year? It was pretty staggering to see the results there, which showed that patient willingness to fill that first script skyrocketed from mid 30s to in the mid 70s percentile. Went from about 36% to over 75%. It was actually 76% said that they would be willing to pursue that and fill that first script. So a very powerful tool here without even changing the total dollar amount. It's just the ability to spread out that cost over the remaining months of the year has a real impact on patient willingness to fill that first script. And that makes a lot of sense when you consider the target audience here, Medicare beneficiaries, because oftentimes these folks are on a fixed budget. Maybe they don't have the liquid funds in their bank account to afford a higher cost biologic or prescription drug at one time, but if they can plan for these payments and spread them out into more manageable payments throughout the rest of the year, then that becomes a lot more attractive to them, and they are willing to fill those scripts. A question that we get all the time is this an option just for true standalone Part D beneficiaries, or is it also true for Medicare Advantage? And the answer is the latter. It's true for both PDP, so prescription drug plan beneficiaries, as well as MAPD or Medicare Advantage prescription drugs. So very important and a great opportunity for all Part D beneficiaries that have drug coverage to take advantage of this plan. But the key is they have to opt in. They have to actually take action in order to do that. So let's look at a couple examples here of what this might look like for a beneficiary. This is a very common example that I've seen referred to often. So hopefully this resonates with folks. Let's say if we were to rewind the clocks and look back in January of 25, a patient was prescribed a higher cost medication that had a coinsurance of about $2,500 total. Well, we know right off the bat that patient's not going to spend more than $2,000 because all out-of-pocket drug spend for Part D beneficiaries is capped at $2,000 starting this year. Now, if the patient did not enroll into the Medicare prescription payment plan, if it was just kind of the traditional path that has always been followed, then that patient would have to pay the $2,000 all at once to the pharmacy when they pick up their medication. However, if they did opt in to the Medicare prescription payment plan, well, then it's going to take that $2,000, require no payment out of pocket at that point of sale. So when the patient actually picks up their prescription, there will be no exchange of payment, no money changing hands. They'll be able to walk out of the pharmacy or receive the mail order prescription for no cost to them. But instead, it's going to bill that patient $2,000 spread out over the remaining months of the year. So as it just so happens in this example, it comes out to about $167 a month, which is a popular number here when talking about Medicare prescription payment plan. A lot of folks associate the M3P with just a $167 per month bill. And that's true for this example, but it's not necessarily true in every case for every patient. So allow me to walk through another example where we can highlight a different monthly amount. In this particular example, it assumes that a patient does not opt in to the Medicare prescription payment plan until March. Let's say that a patient was on a lower cost product, maybe a generic cholesterol medication, maybe corticosteroids, with a $20 copayment in January, as well as a $20 copayment in February. Come March, in this example, let's say that they were prescribed a higher cost biologic medication. If this patient did not enroll in this particular situation for this particular product, and again, this is just kind of a made-up product, but I think highlights the math very well, that out-of-pocket that they would have had to pay just based on their deductible, the amount of money that they've already paid to date, whatever the WAC was of the product, the 25% coinsurance that we're using for this example, you can see pretty sizable out-of-pocket spend for March. Now in January, when they go to refill that prescription, they're still going to have a remaining balance on that $2,000. So they're going to pay that off. And then once they hit that $2,000, it's going to be capped. So $2,000 met and no more out-of-pocket spend for them for any new prescriptions for that product or any other product starting in April and moving on throughout the rest of the year. If a patient does opt in to the program, then you can see here how the math is going to work out, in which case it is a more manageable monthly payment. In this example, as we can see, it's not $167, it's $196. And it is consistent in this example, but that's not always going to be the case. Sometimes the monthly payment might be a little bit higher than the previous month. Sometimes it might be a little bit lower. It all depends on that particular patient's situation with prescription drug spend to date, the product and the cost of that product, the coinsurance that they have, and a number of other variables. So some high-level examples just to show you here, but there is a chance that the out-of-pocket monthly spend for a patient will be different month to month, or will be different than the $167 that's so common when talking about M3P. But just wanted to throw out a couple examples here to hopefully allow folks to understand how this would work in real life for your patients. if anybody has any questions, feel free to drop them in the chat or come off mute. I'm happy to address those. I want to make sure that everybody's understanding the nuance here. In terms of the activity that we've seen to date for March, or through March, I should say, there are some reporting requirements on the part of payers to make sure that they're informing CMS on a regular basis how many patients are enrolled in M3P, how many patients were offered or informed of M3P but chose not to opt in, and a number of other different metrics. The unfortunate thing for us on this call is that that information is not made publicly available, so it's tough to understand at a high kind of meta level how Medicare prescription payment plan is going. So instead, we need to look more anecdotally and kind of keep our ear to the ground on how different offices, how different patients, as well as contacts that we might have in the payer space are seeing M3P rollout. Fortunately, we're seeing a lot of success with Medicare prescription payment plan, both in terms of enrollment as well as patient willingness to pursue those prescriptions, whereas historically they may have walked away just because it was cost prohibitive for a high coinsurance. So that's good news. Of course, there's plenty of stories of frustration where a patient may have called their payer and asked about M3P, and maybe the payer was ill-informed or didn't provide the enrollment form, et cetera. We've heard a few examples of those as well, but to be honest, those are more few and far between. Generally, it seems like this program is working as it was intended, which is great news. Again, this is a powerful tool for patients and something that we know will have a real impact on their ability to get on medications that were appropriate and prescribed to them. I do have a summary here of exactly what M3P is. So I'll share this just as a reminder here. Again, it's a powerful tool. It requires patients to take action. To date, we're seeing some great success stories of patients that have been able to get on medication that historically they wouldn't have been able to just because it was cost prohibitive. So I will pause here and see if there's any questions that folks have or anything that they'd like